So it's very exciting to be here this morning. Great pleasure for me to be here this morning with what will become over the course of the day, I guess, nearly 300 experts and stakeholders who've come together this morning to kick off what will be a year of activity for the Academy on celebrating the 50th anniversary of the Medicare and the Medicaid programs. So before I start, I want to give thanks to some of our leading sponsors. We have quite a few sponsors for this event, but certainly our biggest program underwriters are Commonwealth Fund and Anthem. And also want to thank AARP and the California Healthcare Foundation, the Peterson Foundation, and Kaiser Permanente's Institute for Health Policy for their support for this program today. I think it's remarkable this program that was created 50 years ago is really, in many ways, an unusual American event, given the nature of our country. And it's a truly remarkable program. Indeed, it's several remarkable and very different programs, all under one name. Sometimes very hard to say, if you have to say what is Medicare, it's hard to kind of come up with a simple sentence for it. It reflects the complexity and the diversity and, the characteristic American quality of putting lots of little bits and pieces together to make a whole. Initially, it was modeled on Blue Cross Blue Shield's private health insurance program and relied on the private carriers to administer its claims, and it's become, in its more recent expansions, even more reliant on this interaction between public and private, which I guess also is somewhat uniquely American. It is a program with mandatory participation in some parts, voluntary participation in others. It relies on a mix of payroll taxes for some parts, general revenues, premiums, and different mixes for different programs. In parts, it administers prices directly. In other parts, it relies on health plans and others to negotiate. So it's really a lot of different things. And it was interesting last night, particularly I think for those of you who were at the reception, to hear Uwe's kind of overview of the whole relationship of Medicare to the healthcare system and healthcare pricing. So it's hard when you use the term Medicare to know exactly what you're talking about. But we know one thing. We know it's had a huge influence on the structure and financing of the healthcare delivery system in this country, and in every other sector of this economy. And Medicaid, which was its partner in birth, although they're not identical twins, is even more diverse and more complex. And it's really not even a program, it's 52 different programs. And it has not only hospitals and devices and drugs and physicians and everything else, but it also has long-term services and supports, covers children, families, seniors, wraps around Medicare. It's really a very remarkable set of programs. So Medicare and Medicaid in the next 50 years can only become more eclectic, more innovative, more influential in shaping healthcare, and more influential in influencing the health of the American people than it has in its first 50 years. And today we're going to have a rare and, I think, mind-expanding opportunity to think creatively about Medicare and Medicaid and the possibilities for the next 50 years. And I want to really thank our co-chairs for putting together a very stimulating, challenging program. They did an incredible job of really thinking outside the box about how to approach the challenge of characterizing and thinking about Medicare and Medicaid going forward. Lee Goldberg last night did a really nice job of introducing the co-chairs. I will not attempt to replicate all of the things that he covered. I'll just simply say that we have three marvelous co-chairs this year. Sachin Jain, who is the Chief Medical Officer at CareMore Health and was until recently at Merck. Susan Denser, who is Senior Policy Advisor at the Robert Wood Johnson Foundation, and a lot of other things as well. And I will refer you to their biographies. And Karen Davis, who really needs no introduction in the Academy because she's been such an active partner in the Academy for a long time. She is at Johns Hopkins University, where she is the Eugene and Mildred Lippitz Professor in the Department of Health Policy and Management and Director of the Roger C. Lippitz Center for Integrated Health Care at the Bloomberg School. And I'll say about Karen, also in addition to being, having been so active in the Academy and contributed so much, she's also the author of 2 articles that are in the exhibit lounge. I will encourage people to take a look at those, and they are part of a combination of articles that appear in the latest issue of the New England Journal on Medicine. Well, I'll do this right. New England Journal of Medicine, which is in fact our national publication. And those articles are co-authored with David Blumenthal and Stuart Guterman. And then before we get started, I do want to say a couple of housekeeping things, one of which is that all of these sessions, except session 4 today, are recorded, and the videos are going to be posted on the Academy's website after the conference. And you can join the conference conversation today on Twitter using hashtag NASI 2015. So I want to, without further ado, introduce Karen Davis to kick off our first session this morning. And I want a round of applause for all the co-chairs and their contributions.
Thank you, Larry, but particularly thanks to the Academy for kicking off 2015 in a wonderful way to really celebrate and recognize and grapple with the challenges facing the Medicare and Medicaid programs. So last night was mostly celebration, a little bit of entertainment, which we always get from Uwe Reinhardt. But today we're going to explore in more detail, with the help of Stuart Guterman from the Commonwealth Fund, Medicare's signal accomplishments in its first 50 years, but then we're also going to switch to some of the challenges and potential ways forward. So I'd like to thank the Commonwealth Fund for supporting some of the work that you're going to be seeing this morning, including, as Larry mentioned, the 2-part health policy report series just out in the New England Journal of Medicine on Medicare, origins and evolution, and the moving forward, co-authored with David Blumenthal and Stuart Guterman. So I would like to briefly start with just ticking off what I see as the major accomplishments of Medicare. Certainly, I think we all agree that it's achieved its goal of ensuring access to care and financial protection for beneficiaries, including a dramatic drop in the numbers of people uninsured, increases in life expectancy, and good performance on access to care and financial protection from medical bills. Medicare has also been an innovative leader, and we'll hear from Jerry Anderson about some of that on payment, quality, and delivery system reform, introducing the DRG system in 1983 and the physician fee schedule passed in 89, implemented in 92, as well as the evolution of the Medicare Advantage program and quality measures over time. As we heard from Uwe Reinhardt last night, Medicare has done well relative to private insurance in performance and growth in healthcare spending over the period from 1970 to 2012, but over that period was higher than the rate of growth of GDP per capita. Looking forward over the next 10 years, the projection is that Medicare will continue to grow more slowly than private insurance per enrollee, but what's most important, even slower than the growth in GDP per capita. I find it particularly interesting that the Congressional Budget Office has dramatically lowered its projections of Medicare outlays over time. In fact, if you compare estimates made in 2009 with those in 2014, over the period from 2011 to 2020, Medicare spending is actually $1 trillion less. I think we all saw earlier this week that some of the estimates of spending under the Affordable Care Act are now lower than was projected, but savings and slowdown in Medicare spending definitely better. So lots of good news to celebrate. On the other hand, Medicare faces significant challenges for the future. I think we all understand that it's not total coverage, and that as a result, most Medicare beneficiaries buy or obtain supplemental coverage, but there remain significant financial burdens for those with low and modest incomes or serious health problems, and it's a fragmented coverage system, unlike employer coverage, with separate coverage for hospital, physician, prescription drugs, supplemental coverage, and for some for Medicaid. It is an acute care program that has only limited long-term care services and support, much more needed to really help beneficiaries with complex care needs. Provider payment, that's still largely fee-for-service, although we'll hear about movement toward value-based. And then retirement of the boomer generation and the challenges that will face. So even though Medicare per beneficiary is growing more slowly than GDP per capita, just simply the numbers of people on the program means that Medicare will have an increasing share of the federal budget. So to move forward, we'll hear from Kathy Shane, who will present some work of co-authors Christine Butorf and Martin Anderson about how we might get to less fragmentation of care with a comprehensive benefit package, realizing administrative simplicity and savings. But also, she will share with us some thoughts on incorporating sliding scale premiums and cost-sharing assistance for low and modest income beneficiaries directly in Medicare rather than supplementation through Medicaid, and incentives to obtain care from high-value providers. We'll hear about provider payment reform from Jerry Anderson, looking at how we move from fee-for-service to value-enhancing payment methods, and we'll hear from Lauren Nicholas at Johns Hopkins, who, along with colleagues Marilyn Moon and Eileen Holland, are proposing a new part of Medicare for people with complex care needs. So I'd like to welcome the panel to come forward. We're going to start with Stuart Guterman, who is Vice President for Medicare and Cost Control of the Commonwealth Fund. He'll be followed by Kathy Shane, who was the Senior Vice President for Research and Evaluation at the Commonwealth Fund and is currently with the Wagner School of Public Service at New York University. Then we'll hear from Lauren Nicholas, an assistant professor of health policy and management at Johns Hopkins, and finally, Jerry Anderson, professor of health policy. So that's a brief introduction. Their full bios are in your conference folders. My main job is to point to those index cards on your table. The Academy is following a new procedure this year, and Lee Goldberg will come around, pick up your questions on those index cards, and we'll have them ready for the speakers to address. Indicate on the cards if you want a particular speaker to do that. Okay, with that, I'm going to turn to Stuart Guterman.
Thanks, Karen, and thanks to the Academy for putting this session on. It's a great way to start the 50th anniversary year of Medicare. I'm going to give kind of an overview, a context for the talks that follow, and kind of try to set the stage for those issues. First, again, from my perspective, Medicare has three very distinct and important aspects. It is, of course, a vehicle for coverage. for a large and growing population that really needs the healthcare system to be responsive to them. It also is a program that accounts for a large chunk of health spending and also federal spending, and it's gotten a lot of attention, of course, in Washington. But I didn't put that first because it's important to remind people in Washington that Medicare is not just a budget line item, but actually a very important social program. And third, and this is something that's been really stressed, although at the same time ignored when people were talking about the Affordable Care Act especially, it is a platform for developing innovative approaches to payment and delivery system organization. And I think when people say the ACA took care of coverage but didn't pay attention to cost, they're really not reading the ACA properly, and they're not interpreting Medicare's history properly either. First, let's go back to 1965, which I'm sure is before most of us will admit to being born. But it did have, when it was enacted, an immediate impact. It increased health insurance coverage, of course, especially for the Americans over age 65. It increased access to health care, of course, through that coverage. It increased protection against health care costs, which were a real problem. Although now, looking back and thinking that people were kind of wringing their hands about the fact that the elderly could come home with a $500 hospital bill is kind of ludicrous to us now, but that was a lot of money then, and it was more money than many elderly had. It also, something that people tend to ignore, it decreased disparities by race, broadening coverage, of course, as is true today. Folks in ethnic and racial minority groups had less access to the healthcare system than other folks, and broadening coverage to everybody over age 65 helped eliminate those disparities. And it also spurred desegregation of hospitals. The civil rights law had been passed in 1964, and Medicare, in keeping with that law, required that hospitals desegregate their facilities and their staffs. And with the amount of money that was behind Medicare, that kind of really pushed that issue as well. So a little bit of illustration of those points. In the period immediately before the enactment of Medicare, about half of elderly Americans had no health insurance. Elderly Americans weren't a really good enrollee population for private insurers to go after, and there was no money behind that. So when Medicare was passed, those figures really jumped tremendously, and now, of course, almost everybody who's 65 and older has coverage for both hospital and physician services. The increased access to health care, of course, is shown in the jump in the number of persons seeing a physician during the year before and after, and you see the biggest jump was in the 65 and older population. And you see the protection of against expenses. Now, there are two things to notice here. One, the difference between 65 and 67 was a big jump in mean total charges for health care. So the health system got more expensive immediately, but folks who were covered by Medicare were more protected against those costs than they had been before. And that's the two sides of increasing health insurance coverage. You're going to increase spending because you're going to increase utilization and access, but you're also protecting the folks who need that care most. And I have the percentages of the total in parentheses there because that's something when people point out that Americans are spending less money, less of a proportion of total health spending out of pocket, and some people even put that forward as a problem. The fact is they're spending more of their incomes on health care, and that's the big problem. And then, of course, utilization. More people had access, especially to hospital care, and the difference by race here is shown to have evened out once Medicare was put in place. And in fact, as Karen pointed out, Medicare beneficiaries do report fewer access problems and greater protections against the financial burden of illness than any other insured population, especially the elderly Medicare insured. But Medicare, it was enacted in 1965. That was 50 years ago, and there's been a fair amount of evolution over that time. As Karen mentioned, eligibility has increased. The disabled and the ESRD population particularly were added in 1972. The drug coverage was added beginning in 2006 in the Medicare Modernization Act of 2003. The role of private plans has expanded. It actually has been private plans have been part of the program for a long time, but that role has evolved over time as well. And then there have been a series of payment reforms to try to move from the 1965 world of reimbursement to a more modern and, in fact, future-looking set of rules about payment. And quality improvement has been an increased focus in Medicare. The Affordable Care Act had a number of provisions, as I mentioned before, that moved forward on all these fronts, but the system does face ongoing challenges. Rising expenditures are constantly cited. Uwe's point last night about Medicare not being unsustainable, but rather being a challenge. It's still a challenge to wrestle with Medicare costs and how they're projected to grow over time. But I wouldn't call it unsustainable. And in fact, we could look at it this way. Society's made a decision to produce more elderly people. And now we're wrestling with the notion that we might have to actually pay for the implications of that decision. But I don't see anybody opting out of that decision. Medicare was designed as an acute care program, and now it has a population that's increasingly bearing the burden of chronic illness, and we need to get better at doing that. There's fragmentation in the structure of Medicare because of the way it was put together, and that could be addressed and will be talked about in later discussions today. And of course, there are coverage gaps. There's still no out-of-pocket limit. Long-term care is a growing problem, and one that is probably the most scary thing about the thought of growing old. And it's not dealt with in Medicare. In fact, many Medicare beneficiaries are surprised when they become eligible for Medicare that Medicare does not cover long-term care. As Karen pointed out, Medicare per capita costs are growing more slowly than GDP, but because of the increase in the Medicare population, Medicare total costs are projected to grow faster than GDP, so that's an illustration of that point. Many Medicare beneficiaries still have to spend a fair amount of money on health care, including premiums for Medigap, for supplemental coverage and things like that, but also out-of-pocket and deductible and long-term care expenses. And that's particularly hard on people who have low incomes, obviously, and also people who are sick. And Medicare beneficiaries with multiple chronic conditions do account for a very high proportion of total Medicare spending, and that needs to be dealt with. So the conclusions, Medicare has been a successful program over the 50 years. It's facing a number of challenges as it moves into its second 50 years. And Medicare should be looked at as a major player in addressing not only those challenges, but also helping to fix the broader healthcare system. And when we talk about Medicare and the broader healthcare system, we really have to talk about them together, because the factors that are driving the problems that are faced by Medicare and more broadly are the same factors. They may play out somewhat differently because of the different populations, but they need to be addressed as one whole unit. And I want to thank my co-authors for the New England Journal articles, David Blumenthal and Karen Davis. Thanks a lot.
I guess there's a clicker, and I click forward. Yes. Hi, I'm Kathy Shane, and I'm going to be the first on the panel to deal with some of the issues that Karen and Stu have laid out for you, and specifically access and affordability. What you just heard from Stu is that Medicare has been a success story. He didn't mention that not only did their health improve, did the longevity of the population improve, but poverty rates went down when we brought in the Medicare program. I brought income security, especially against acute care, that really was in such high demand. People who talk about it coming in, there was a little tab on do you want it or not on Part B when people were first opting in, and people would tear off the no, because they wanted you to make sure they knew they wanted that policy. So there was an overwhelmingly positive response, I want in. But what has happened since then is that we froze the benefits in place. And so they reflect a benefit structure that was in place in 1965. And I actually can remember 1965. I wasn't one who was born after. And at that point, private insurance had a part for hospital, that was the cross part, and the shield part was the doctor part, and it didn't come with catastrophic. It was an extra policy that was just starting to come into the private market. So you have a benefit package that's got separate deductibles for hospital and doctor with an open-ended exposure, and as a result of that, people buy supplements. Anyone who can afford it knows that as they age, past retirement, they have a lifetime of reserves of whatever they've saved up. They better be ready. So we have a large number of people supplementing it. There have been some additions to try to address the low-income side, but that also has been very fragmented and piecemeal throughout the years. So we've left a lot of holes, and as I will do a very bird's-eye view, when you look at the current low-income help that people get, either with Part D, the drug part, or Part A and B, it doesn't make a lot of sense when you lay it out. It's come in very incrementally. So I'm going to lay out, with the co-authors that were mentioned on the first slide, two possible policy approaches. The first is to start going up the income scale, expanding help with both the premiums and the cost sharing, and I'm just speaking about Medicare-related cost sharing now. I'm not addressing the long-term care services that aren't covered, or a policy that would both go up the income scale with support for premium and cost sharing and bring in a new integrated benefit package. And we've written on this before. At the end of my slide pack is posted the article Karen and Stu and I worked on called Medicare Essential, that said what would happen if Medicare itself offered its own supplemental policy and could integrate the way it treats benefits. It could be a much simpler process for beneficiaries to have one premium they're paying rather than potentially three when they go out and buy a Medigap and a Part B. So these are preliminary estimates that I'm going to be showing you, not the baseline, but the estimates. So later on, I would appreciate that you don't circulate the slides, particularly because the numbers have been changing and they will continue to change. Just to give you a sense of what do we mean by the gaps in core benefits, I'm not going to go into a lot of detail, but if you think about what the income of beneficiaries are, the median income is about $23,000. That means half have incomes lower than that. There's a $1,200 per episode hospital deductible, which all by itself comes to more than 10% of a person who's near poor's income, just the deductible for a hospital. There's a Part B premium that is now up to almost $1,300 a year, so it's a good deal when you compare it to buying what the full policy would, but again, on incomes of $10,000 a year or $15,000 a year, it's a lot of money. So you need to buy supplements if you can to protect yourself because of this open-ended 20%. For the low-income population, we've gone up to about poverty for premium help. They don't have to pay their Part B premium, and for help with cost sharing, but we ask a beneficiary who's getting that premium relief to go to the Medicaid program. So they've got to go to a separate program to get their Medicare premium paid and their Medicare cost sharing paid. So we bring in the states, it's an application process, there's an asset test. If you're a little bit above poverty, you only get help with premium, and that stops at about 135% of poverty. When drugs came in, the drug policy, as all of you know in this room, Part D, had a huge donut hole in it, had a lot of cost sharing, also had a premium, and people said if we want a lot of participation in low income, we've got to help low income people buy this extra drug benefit. So there, it went all the way up to 150% of poverty and did a sliding scale on both premiums and cost sharing. So it came in on both sides of the equation, much as what we've done with the Affordable Care Act for the under 65 population, saying care is only going to be affordable if when you go out and get care, you're not facing costs that are high. You'll only be able to afford insurance if the insurance premium compared to your income is affordable. So there are two sides of affordability. So as a result of what we have now, we have very complex choices and a lot of navigation. You've got to navigate private insurance markets as well as the Medicare side. You've got to understand where to go in your state for supplements, for cost sharing and premiums for A and B. You've got a separate set of applications if you want D supplements. They have their own asset tests, and they're not very coordinated. Now, we started to add up administrative costs within the U.S. health system several years ago, and we're still adding them up and finding people. But we probably, if we went out and found all those Medicaid clerks and other clerks around just processing eligibility, and remember, this is a population whose income is not changing dramatically year for year, especially the low-income population. They get Social Security and have a little bit of it. But we've got people applying annually, a lot of churning, a lot of marketing in private sector. So there's an opportunity here to both integrate the benefit package, simplify and lower administrative costs, and redirect some of those resources. So starting first with the picture of where we are. As Stu said, and you can go back over time and look at the cost relief that Medicare gave when it came in, but at the same time, over that 50 years, medical care has become more expensive, and the definition of what we need in care has expanded. So as a result, our estimates are, as of 2014, about 25% of all beneficiaries are spending 20% or more of their income on the combined costs of premiums and cost sharing. You can see it's much higher. It goes up to the 40% range for the low-income population. If you look at just premiums alone, a high percent are spending more than 10% of their income just for the premiums. So people are trying to supplement. The Part B premium alone comes to a 10% of income as you start to get above poverty. So this is not an insignificant premium. And in some other work we've done, I've done a lot of work on what we've called the underinsured, people who, despite having insurance all year long, are exposed to at least 10% of income. We've got 22% of the Medicare population who would be considered underinsured if we use that 10% definition, and a third of the people who are low income. Now, only about half of those out-of-pocket medical care costs are covered Medicare benefits. So part you're seeing is the gap in long-term care support. There's no dental, there's no hearing. For routine hearing and vision, people are paying out of their own pocket. So what we've looked at, and I'm going to speed through the rest of this a little bit, is what would happen if we went up the income scale as high as 200% of poverty. We've also looked at up to 150% of poverty, and helped a bigger share of the population, the beneficiaries, with the premium side of the equation, the Part B premium and their cost sharing, And what would happen if we did that and we provided an integrated package that gave you just one deductible, limited out-of-pocket costs, sold it for an extra premium, but for that extra premium, it would be self-financing. So you'd be buying your Medigap, your supplement directly from Medicare, and it could be run as a single program. So the impact of these two together or separately is to almost cut in half the number of people with high out-of-pocket costs measured as 20% or more. And just low income alone, moving up the income scale, drops the low income side substantially. The other thing that happens is you start to look at a more equitable distribution of burden. That instead of having higher income spending a relatively small share compared to low income, it starts to even out. We remove those huge differences. When you add the integrated benefit package as an option, you start to reach higher income people as well, because the Medigap policy they're buying is quite expensive. It's got a high administrative load, so they're getting more for their premium dollar in benefits than they're getting now. We cut the number of underinsured by nearly a third to more than 40%. And these are just people counts, so it has a big impact on improving the financial security of the policy by doing these. It's not free. A lot of people get helped by this, but to help them, you have to spend federal money. To come in and give additional premium support, give additional cost-sharing support. It could be phased in, but the offset of a $40 billion relief of expenditures for beneficiaries means you're going to have to be paying for it in some way. Right now, we have the Medicaid program paying for part of these costs, sharing it with the federal costs. If the federal government took it all over to streamline administrative costs, they could recapture some of that savings for the Medicaid program. So there's a real opportunity as we think of the next 50 years to be really thinking broadly about what do we mean about the next 50 years going forward. We want a program that serves its beneficiaries well, that stops people from going into debt for medical care, avoids going without care because of cost. The one chart Stu did not show you is our international comparisons where the U.S. is an outlier for the elderly. Our elderly are much more likely to go without care because of cost, to face bills, debt problems than our other countries. So Medicare's doing a good job, but we could do better, and we could be building a more secure future. And it's up to all of us, I think, to say, how could we phase this in? What pieces are the first things we should tackle so that the beneficiary population is a healthy, secure, and lives a long and happy life? Thank you.
Thank you. I'm going to be talking about a group of beneficiaries that may be particularly poorly suited by the current Medicare benefit package, which is beneficiaries with complex care needs. And this is going to be some joint work with Marilyn Moon, Eileen Holland, and Karen Davis. To give you an overview of our talk, we're sort of motivated by this basic point that current Medicare benefits are poorly suited to beneficiaries with complex care needs. We've known for a long time that a small number of high-need beneficiaries drive a non-trivial portion of Medicare spending. And this is partially because of a need for care coordination that doesn't necessarily take place, both across sites of care for people with a large number of care needs and incorporating both health and social care. Currently, we don't have coverage for things like informal care, support in the home that can be very important for preventing expensive hospitalization episodes. And so we've done some descriptive work to highlight who these complex care need beneficiaries are. In the remaining slides I'm going to show you, these are based on the population that has 2 or more activities of daily living limitations or significant cognitive impairment, so cognitive status consistent with Alzheimer's disease and other dementias, or very high Medicare spending. This is people in the top 5% of the fee-for-service spending distribution. And as you'll see, many of our beneficiaries fall into several of these categories. So overall, the complex care needs population accounts for 20% of Medicare beneficiaries. The vast majority of this group are in fee-for-service Medicare, where they're representing only 18% of the beneficiary population, but about 36% of spending. Roughly half of this complex care needs population has is coming from the physical limitations only group, and then we've got a small number coming from high spending only, and 2% of these guys are coming in with cognitive limitations, and the remainder are a combination of multiple factors. So what does Medicare spending look like on this group? This is limited to those in fee-for-service where Medicare spending is known, and you'll see that our complex care needs group is disproportionately represented in Medicare spending. So about 82% of spending in the bottom 95% of the distribution is coming from people with no cognitive or physical limitations, whereas only 45% in this high needs or in this high spending population is driven by this group. A large share of the remaining spending, 32%, is coming from the physical limitations group, and then we've got 7% coming from our sort of most vulnerable group with both cognitive and physical limitations. These complex care needs patients are disproportionately in the low-income group that Kathy focused on in her talk. So although they're much more likely to be below 200% of the federal poverty level, these are not necessarily people who are duly eligible for Medicare and Medicaid. So there's a large group that's going to be subject to very high out-of-pocket spending without sort of the protection of Medicaid on the side. In this slide, we've documented both Medicare and out-of-pocket spending for our complex care needs beneficiaries compared to non-complex care beneficiaries. And as you'll see again, similar to what Kathy pointed out, with large numbers of Medicare beneficiaries spending very non-trivial shares of their income on medical care, and particularly out-of-pocket spending. This is particularly pronounced for those at low levels of income, so below 200% of the poverty level, and greatest for those with the complex care needs. These are people who often live alone, so we've sort of as a default expected informal and family caregivers to pick up a lot of the slack in helping these people with their care needs, and you'll note that many of them, slightly more than half of complex care needs beneficiaries, are living by themselves, and it's not necessarily realistic to think that there's going to be someone in the house able to provide some of the assistance that isn't covered through Medicare. Furthermore, these are problems that persist for many years. I think many of us have seen figures suggesting that healthcare spending in the last 2 years of life accounts for a significant portion of Medicare spending, and you may be tempted to think that this very sick group is part of that group. That's while the complex care needs beneficiaries are more likely to be in the last 2 years of life, the vast majority of them are not, and so we've got about 86% of those classified in 2010 continue to live for at least several more years with these care needs, which tend to, as we all know, these are degenerative diseases, and so it's going to get worse and sort of need some ongoing care. So what are some of these needs that aren't being met by traditional Medicare? The first is care coordination that might better deliver services for this group. We think particularly critical are medical and non-medical interventions. So you can think of something as simple as sending a handyman who might be able to put grab bars in a bathroom or remove throw rugs and other fall risks. And finally, there's a lack of protection for caregivers, right? We hope that family members will provide very important unpaid, unsupported social and near medical services, and providing things like caregiver respite, caregiver education that might make it easier to do some of these things are another important gap from the current program. So why would it make sense to carve out a separate Medicare benefit that could service this complex care needs benefit, or this complex care needs population? Certainly the most obvious is improving quality of care and quality of life for these patients. So things like focusing on individual care plans and meeting the social and informal care needs of this group as well as the medical care, and then the strong possibility of lowering costs, which we know continues to be an important issue in Medicare. So we can think about the potential for more appropriate care to reduce the need for some of these expensive acute episodes, sort of relying on home care more rather than long-term care. Of course, these are sort of hypotheticals. We don't have good estimates for where sort of dollar figures and how much savings might be possible, but sort of optimistic that would be achievable. So what should such a benefit look like? We would rely on sort of compensating a particularly appropriate entity to coordinate care on behalf of each beneficiary. This would involve offering both appropriate medical and non-medical care to support patient independence. We want to give these entities greater flexibility to deviate from the current sort of Medicare benefit structure. So you would sort of ideally want different services covered for different beneficiaries as appropriate, which is a design challenge that we pose to many of the members in this room to start thinking about. And particularly finding ways of limiting cost sharing, particularly for low-income beneficiaries, to avoid sort of discouraging access to necessary care. How would something like this be delivered? We need to see new entities coming out to manage these benefits and be reimbursed for doing so. So we'd like to see complex care organizations, something analogous to an accountable care organization, but targeting these high-need patients with the ability to both determine eligibility and coordinate and deliver appropriate services. So we would want to use a lot of policy levers available to us, both giving these entities the ability to share savings, relax Medicare coverage policies, and to do this, we really need to see some more testing of both ACOs and comparable models. So I'd say more Medicare demonstrations quickly to help this population. Thanks.
So I was scooped. Essentially, this presentation is about value-based purchasing. Some of you may have heard that the secretary wrote a paper that came out in the New England Journal of Medicine today about value-based purchasing. So I've got a problem here. I mean, she basically said what we wanted to say. Maybe she took our ideas, maybe she didn't, but essentially, you know, we were scooped. So now I've got a problem here. So I could sit down and say, just read her article, or since I have the forum, I will talk about a few things that she didn't emphasize. So back in 1965, I wasn't thinking about Medicare. I was thinking about a Mustang. I mean, you know, that's what a 14-year-old boy thought about in 1965. But you know, it's related because it was the best car ever, and probably in 1965 the payment system that we had for 1965 for hospitals and physicians was the best you could do, and and probably we thought in the Medicare program that was pretty cool. But what we had was almost immediately, really in 1967. The Medicare program started saying, we've got to change this system. And they started with hospitals, but they moved on to everything else. And so you had the DRG system that I helped develop in 1983. In 1989, you had RVRVS. And throughout this period, we were making these changes. And what it was really most of the payment changes, if you look at what's happened over the past 50 years, have been really started by Medicare, led by Medicare. And if you look at the systems, most of the private sector systems have adopted what Medicare has done. Probably the best example is RVRVS, but a lot of them are using DRGs and other things as well. So Medicare in payment has been the leader in these types of activities, not the follower. But, you know, Medicare can't rest on its laurels, needs to move forward. And so essentially what we're now trying to figure out is how do we make changes? So we've got to move on value. One of the things that we've got to start figuring out is silos. Karen, as many of you knew, grew up in Oklahoma, so I put silos up here for her so she could relate to it. But essentially, what it is we have hospital payment systems, and we have physician payment systems, and we have pharmaceutical payment systems, and we have them all operating in silos. And you know, we're going to talk about bundling, but essentially, much like we have our delivery systems and our benefits in silos, we have our payment systems in silos, and that's something that we're going to, and value-based purchasing and everything does, but essentially it's really to get out those things. Now, we also want the private sector to use the Medicare program. And in a lot of ways, we make it easy. And probably the most easy way we make it is we make the payment methodology very transparent. And having a transparent methodology in the Medicare program makes it very easy for the private sector to adopt something like RVRVS. But we've got to work in a number of things. The DRGs really apply to Medicare. They don't apply to the rest of the sector. Medicare could easily develop all-payer DRGs and really should in order to make it much easier for the private sector to do it. It also has some methodological problems, primarily in the outpatient area. I mean, if you take a look at the methodology that Medicare has developed for outpatient payment, it's not site neutral, it's terribly complex. It really isn't something that the private sector can easily adopt. And so that's the kind of work that I think Medicare ought to be doing. So the next generation, Secretary Burwell says it, we're saying it, it should be blended, it should be bundled, it should be global, it should be price and quality transparent, and should be based upon the value for the Medicare beneficiary. So that, essentially, she writes it, we write it, we all agree. What they do, if you look in a little bit more detail, is they have now developed the payment methodology into 4 categories. Category 1 is where you basically have no value involved. Category 4 is payments almost based totally on value. So an example of something where payment is based pretty much totally on value is some of the payment systems for managed care organizations, but really only a small subset of the managed care organizations. Those where the value both is in the payment to the managed care organization and what the managed care organization uses to pay the providers. And those are things like in Kaiser and Geisinger and Intermountain. What we need to do in things like Medicare Advantage to move you to step 4 to the most quality things is if you think of most of the managed care plans, yes, the managed care plan gets a capitated payment, but the providers working within the managed care organizations typically are still paid fee for service. And so what we need to start doing is moving the payment methodology that the providers get within managed care to a much more value-based capitated system. So just paying United Healthcare or somebody else that amount of money doesn't really get you what you want. So if you want it to be a 3 or a 4-star quality program, maybe what you want to start thinking about is making sure that the providers have the same incentives that the managed care plans in order to provide qualities. Something to think about. Accountable care organizations make a lot of sense, sort of managed care light, but essentially what you have is the wrong payment system. I mean, what you have is essentially a shared savings system. And in a shared savings system, just makes no sense. I mean, essentially, if you give somebody $100 and then you say, but if you cut it to $90, we'll give you half of the savings. Now you've got $95 and you've lost $5. Well, that just doesn't make any sense for anybody to lose $5. And so, a lot of more. So you've got to move into a different payment system, which is more value-based, more on the basis of payments. Blended payments, bundled payments work very well, but what Lauren talked about was the fact that we want to do it for people with complex care, coordination, whatever. Those people are very hard to have bundled payments. It's very easy to do it for an episode of care. It's very hard to do bundled payments for somebody on a long-term chronic condition. And as you see, those people have it for a long period of time. We want to have value-based payments. We can talk about that in much more detail. Again, Secretary Burwell did a very nice job, so I don't need to do it. What I want to talk about a little bit more is price transparency, because I think it's really the key to the Medicare program being adopted by everybody else. And most every part of the Medicare program is price transparent with one exception, and that's pharmaceuticals. And the pharmaceutical payment methodology is not price transparent, and so the private sector cannot adopt it as a methodology for payment. It also is separate and distinct as a payment methodology, and so it makes it very difficult to bundle pharmaceuticals into everything else. So as we start thinking about value-based purchasing, bundled payments, whatever, we've really got to pay a lot of attention to the pharmaceuticals because they are right now a complete outlier. They're what Burwell would call a number one, not unrelated to quality, unrelated to everything else. So we've got to essentially figure out how to do with it. So that's going to be the challenge, I think, in value-based purchasing, because the people who have multiple chronic conditions that Lauren talked about are taking an average of 30, 40 different drugs. They've got to be integrated into the system, but they are totally separate and distinct from the payment system. So we've got to keep it simple. But the bottom line here is essentially we want to have something that's price transparent so that people in the private sector can adopt the system so everybody is working together. And the one challenge for me is the whole issue of pharmaceuticals and how do we get that very critical part of the Medicare payment system to be in line with the rest of the Medicare payment system. Thank you.
All right, I encourage you to put your questions on the index cards. We'll go around and pick those up. I see some being held up there. But Kathy, I wonder if you could start us off by letting us know if there's anything in the international experience that Medicare should be looking at as a possibility for reform in the future.
Karen tosses a nice, easy one my way. You know, there are a couple different, I'll be quick on it. We have written some pieces on this, but just starting on the payment side, that, as Uba mentioned last night, the rest of the world stood up and watched when we brought in DRGs and said, we like this idea a lot. Now, what was interesting to look at internationally is they were coming from a full budget for a hospital similar to the way you'd run a school. Here's your budget for the year. And there were queues. People didn't necessarily respond to productivity incentives, you know, so you just close your doors when you take your last patient and say, I'm full, and you don't have to get people out. So they wanted to move to something that was more activity-based or person-based. So they took our DRGs, but what they did is said, why not have the doctor be part of the DRG? If we're paying for hip and knee replacement, bundle the physician into it. What about the 30 days of rehab that happen after the person leaves the hospital? So there have been a lot of expansions when you get to the acute care sector of thinking about that basic, you know, how are we paying for a hospital with a little bit more continuity, that before I get to the hospital and after. So there are interesting variations because the countries are not doing them all the same, and learning from that. On the other payment side is there's been a lot of innovation on primary care. Many countries start with a stronger primary care system than we do from the get-go, saying they think there should be more equity with the salaries of primary care doctors and specialists. But they've moved to blended payment where part of your income is coming from per person per month. And the notion of that is that's what your infrastructure, that's paying for your nurse, your nurse's aide, time on the phone with somebody. You don't have to have a visit all the time. And it's where we can put quality and extra money. And the rest is a visit rate. So people are all sorts of blended mixes, 40% of the income from one piece, 60 from another, 30, 70. But there's been a convergence around this for both giving physicians rewards if they work hard, if they spend longer hours, see more patients, they're getting it through the visit rate, but giving them the ability to say, I'm just going to talk to you on the phone. I'm going to do a group visit. I can bring in an IT system that handles you well with IT, with telehealth, without having to turn everything into a fee-for-service. So a very interesting piece. And then last, but real quickly, since I spoke about benefits, there is no country but us, and maybe a little bit of a Swiss exception, that exposes primary care to deductibles. They all, if they have cost sharing, they exempt primary care or turn it into a nominal payment because they want people in the system. Primary care is not expensive. So the benefit design values primary care, puts a cap, and there's been a lot of value-based benefit design, particularly in the drug area. France, if a drug is highly effective, an essential medication, but it's expensive, it goes on the lowest cost-sharing tier because you want patients to get it, rather than it's high cost, so we're going to put it on a high tier. So they've thought of dropping co-payments for highly effective medications. For chronic care, they have chronic care regimens that the doctor and the patient agree on a set of activities, what's it going to look like. The patient doesn't have cost sharing for those services that are in. So trying to give people rewards and give physicians an incentive to start thinking about care plans. So these vary country by country, and it's very interesting to watch how they fine-tune them when they do or don't work, but both on the payment side and the benefit design, I think there's a lot to learn.
Lauren, there are several for you. Obviously, you've defined the complex care patient as those with physical or cognitive limitation or high cost. So the question was to better understand the high cost beneficiary that doesn't have physical or cognitive limitations. So that was one. The other have to do with contrasting the complex care organization with Medicare Advantage special needs plans. So, could complex care organizations be introduced in Medicare Advantage? Is that a good place to start? How are complex care organizations different or better than special needs plans? Couldn't the same results be achieved by special needs plans with some policy modifications?
So that is this one on? Okay. Great. So I guess I'll start with your first piece of the question. We were also surprised that there were high spenders who weren't reporting sort of difficulties with particularly physical limitations. Cognitive limitations were less surprising just because these both tend to come later in life and in conjunction with other physical disabilities, and we were restricting the cognitive decline to those who were sort of very far out in the tails. So there's definitely some mild cognitive impairment among some of our high spending group, but not sort of sufficiently bad to sort of be consistent with dementia. And some of this does sort of stem from people having very expensive acute issues versus sort of a complex and persistent need. We think it's sort of important for folks who are going to be in these really expensive episodes to have a program that provides some amount of financial protection. And so one of the things that you would need to think about and that we would have our complex care organizations doing is, are you certifying someone for permanent entrance to this program, or can we sort of take care of you in a shorter term and then move back to fee-for-service or an MA plan for a more appropriate benefit. And sort of related to the MA piece of this and the special needs plans, I think that is sort of a place where we've been trying some of these things, right? And is, I think, expanding that sort of experiment does give us a good place to start. Some of the things that would need to be changed are sort of improving geographic access and equity in these plans. Currently, a lot of your MA benefit and availability is going to be a function of where you live, and that's sort of going to be potentially particularly devastating for this really high need group. And the other piece that we really want to focus on is greater integration with long-term care, with social care, with things that really aren't part of the traditional Medicare package at this point. So we would need sort of changes in policy that would allow the special needs plan or another organization to sort of provide the most appropriate care, and rather than most appropriate constrained by our 1965 benefit package.
So, Jared, somebody who doesn't live in the acronym world wants to know what DRG and RVRBS are.
Okay.
But
an
then
easy one.
we also have a question about what changes have been made to the RVRVS fee schedule since William Schau first proposed it, and what are the implications for future attempts to reform provider payment?
So DRGs are diagnosis-related groups developed by people at Yale University and have gone through constant modification throughout the period since 1983. RVRVS is Resource-Based Relative Value Scale. I feel like I'm teaching a class here. And it has gone through a number of changes. Probably the major change is that they have essentially kept the specialty payments quite high and continued to increase specialty payments where they have not increased the primary care payments nearly as much over time. One of the things that they did do recently is starting to pay for care coordination in the RVRVS system, but it's quite limited in that the dollar amount is very small, but probably more importantly, it gives an incentive for the primary care physician to be engaged, but it provides virtually no incentive for the specialty physician to be engaged. So the people that Lauren was talking about are people who typically are seeing 13 different doctors during the year. And yes, you can pay the primary care physician $40 to do care coordination every 3 months, but if that primary care physician doesn't have any tools or any incentive for the specialty physicians to participate, the system doesn't work very well. So that's essentially, in terms of working with Lauren's thing, we've got to figure out a way for the specialty physician to be engaged in the process.
Well, I've got a ton of really great questions here. Unfortunately, we're also toward the end of this session, so I'm going to direct this one last question at Stu. Where would the suggested reforms come from? Congress, CMS, who leads, who makes the final decision? And particularly, a lot of these questions relate to what is value, how do we really reward the kind of care we would like to have beneficiaries receive?
Okay, an easy question to end up. You know, the ideas come from everywhere. The Affordable Care Act created the Center for Medicare and Medicaid Innovation, and they have the authority, unprecedented authority really, to test a whole variety of ways to improve the payment and delivery systems, and hopefully some of the ideas will come from there. Although I have to say they face a particular challenge because they've got a lot of initiatives going on. There are a lot of initiatives going on in the private sector. Healthcare spending has slowed down. I think by now we can get past the it's only the downturn in the economy that's driving this. There's a different atmosphere if you talk to providers out in the provider community, that, you know, the realization that they need to figure out how to do things differently, but they need a clear and consistent message about what differently means. The challenge that the Innovation Center faces is to be able to attribute success to any of the individual mechanisms, because that's what the authority to spread those and continue those approaches depends on. And it's kind of like asking, you know, which thruster on a moon rocket is the one that enables the rocket to leave the Earth's gravity. You know, there are a lot of things going on. One could argue that all of these things together and none of them individually is leading to the kind of change we're seeing. But somehow we have to pull these things together. The ultimate authority to change the payment system, other than the Innovation Center initiatives, of course, comes from Congress. But the ideas come from everywhere, and hopefully many of the ideas would come from both the provider community and the beneficiary groups, because they're the ones who are going to be at the point of main contact that really drives health spending.
Thank you. I think we're going to have to call it to a close. Join me in thanking our panel. I would like to remind you to fill out the blue evaluation form that's in your folder after each of our sessions. We are going to take a very fast 10-minute break, and then we will come back, and there's coffee in the exhibit lounge next door. But we'll come back for session 2, the changing face of American health and healthcare. Thank you very much.